Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientists monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host and moderator for today's webinar. Today, Dr. David Miklowitz will present Adolescents with Bipolar Disorder, Tips on Coping for Families. The Brain and Behavior Research Foundation is committed to alleviating the suffering caused by mental illness by awarding grants that will lead to advances and breakthroughs in scientific research. The Foundation is the largest private funder of mental health research grants. Since 1987, the Foundation has awarded more than $346 million. 100% of all donor contributions for research are invested in grants to scientists who are working to find breakthroughs in disorders such as ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, obsessive-compulsive disorder, post-traumatic stress, and schizophrenia. I'm delighted to introduce Dr. David Miklowitz. Dr. Miklowitz is a professor of psychiatry in the Division of Child and Adolescent Psychiatry at the UCLA Semel Institute and a senior clinical research fellow in the Department of Psychiatry at Oxford University. Dr. Miklowitz is a recipient of numerous foundation awards and grants, including a NARSAD Young Investigator Grant in 1987, a NARSAD Distinguished Investigator Grant in 2001, and the Foundation's 2011 Colvin Prize for Outstanding Achievement in Mood Disorders Research. Today's webinar will begin with Dr. Miklowitz's presentation. This will be followed by questions and answers. To submit your questions, please use the Questions tab on the control panel on your screen. Please feel free to submit your questions throughout the presentation. Following the presentation, I'll present your questions and will address as many of them as possible in the time allotted. And now, I'm pleased to introduce Dr. David Miklowitz. David, the floor is yours.
Thanks very much, Jeff, and it's a real honor to be here. I have a long history with BBRF, as Jeff said, an organization I admire and appreciate very much and really helped me get started in the field. I know that we have people on who are clinicians, researchers, family members, parents, agency representatives, so it's quite a diverse group, and I'm pleased about that. We're going to be covering adolescent bipolar disorder from a number of different angles, both psychological, medication-wise, different strategies to use at home and in the clinic, and I'm hoping it's useful for you. So just to move forward, most of us know what mania is. These are episodes of high intensity with elated mood or severe irritability. Adolescents have these in the same way that adults do. They usually last at least 4 to 7 days unless they're interrupted by some kind of emergency treatment. We see grandiosity. It is not the same as just explosive outbursts of irritability. That's one, I think, misconception in the community right now, is that episodes of activation with irritability necessarily make bipolar disorder. You really have to have a combination of symptoms, including increased energy, decreased need for sleep, grandiose ideas, speaking fast, and also alternating with lower mood. So depression, which of course can go from mild to very severe, usually lasts 2 weeks or so. Some people feel very tired, wish they weren't alive, feel worthless, talk and move slowly, feel like their heads are empty, or that they have trouble making decisions and aren't as interested in things as they once were. People with bipolar disorder can vary between those two extremes. Some actually have those symptoms at the same time, which we used to call mixed episodes. Now we refer to that as a fifth digit code. So, and also just to remind everyone, there's bipolar 1, where people go back and forth between major depression and mania, or mixed episodes. and there's bipolar 2, where they go from severe depressions to milder hypomanias. Now, the diagnosis of bipolar disorder in kids tends to be complicated. Let me let you know of one of my biases here, which is that I think the diagnosis is a lot clearer when we're talking about adolescents than it is when we're talking about younger kids. There is evidence that the reliability of the diagnosis starts dropping when we start getting into age 10 and 8 and 6. The reliabilities just become very low. We end up diagnosing a lot of kids with not otherwise specified disorders. And so much of the disagreement about bipolar disorder really, I think, refers more to the childhood population. I wouldn't say our reliabilities are excellent for adolescents, but they're certainly better. We know that about 2.5% of adolescents will have a full manic episode or a history of bipolar 1 or 2 disorder. We know they're very much at risk for negative outcomes, including school problems, substance abuse, suicide attempts, or at least ideation, and problems with social functioning. This is a highly genetic disorder. We've known for a long time it runs in families. Of course, other things run in families too, like money and religion and political beliefs. So we don't know yet what genes actually cause bipolar disorder, or what, although we certainly have some excellent minds working on that question. We know that youth are more at risk than for a genetic background than are adults. So if you look in the family trees of kids who have the diagnosis, they're more likely to have relatives with bipolar 1 or 2 disorder. It tends to be a harder disorder to treat, and kids tend to be more symptomatic between episodes than if they have the adult onset version. One of the things that we know is that there's some convergence in terms of when the onset of this disorder occurs. If we ask bipolar patients to describe their first episode, most of them, about half of them actually, will describe an episode happening before age 18. That varies from anywhere from 32% to 65%. But if you ask them now, what about childhood or middle years, 10 to 12, 13, then we're down to somewhere between 8 and 28%. So probably somewhere around 1 in 5 has an onset before age 13, but more like 1 in 2 has the onset before age 18. So we certainly see a jump in episodes of mania in adolescence. So that's important to keep in mind. There really are differences between children and adolescents in terms of the certainty of the diagnosis. Now, one question that frequently comes up is, how do we tell what's bipolar disorder, what's being a normal teenager? This is something I hear a lot from parents. We do quite a bit of family educational work, family intervention, and it's a very good question. We know that healthy teen behavior usually involves a certain amount of risk-taking, a certain amount of mood instability, and of course family conflict. We know that we see the same 3 things in bipolar teenagers. The real issue is the degree of risk-taking, the degree of mood instability, the degree of family conflict. Family conflict in bipolar disorder can be constant. We can see kids doing things that really get them into trouble with the law, or having unsafe, risky sex. One kid I worked with, his friend said that when they went skiing together, it was always him that somehow got the ski patrol involved. They did something that alerted the authorities or got them in trouble in some way. Most teens, many teens, sexually experiment or experiment with drugs. Bipolar teens may get into very abusive and unsafe sexual situations, and they may become quite addicted to substances very early on. But probably the best discriminator between being a regular healthy teen and being a bipolar teen is whether you have these symptoms together, such as the ones I showed on the comic strip earlier. If you have irritability and grandiosity and a decreased need for sleep, that's much more likely to signify bipolar disorder than is the occasional isolated mood symptom. Or healthy teens have occasional sleep irregularities. They certainly can be argumentative and rebellious, but you rarely see them be overtly hostile and irritable across contexts or stay up most of the night for several nights in a row. So really we're talking about degree, severity of symptoms, clustering together of symptoms, and to what degree are these symptoms impairing. And yet we still can have questions at an individual level. Now, all of this, of course, can be very hard on parents. Parents are really struggle to know what to do. This picture was given to me by a parent who said, if you want to know what it's like to be parent of a 16-year-old with bipolar disorder, this about sums it up. That's me on that string. My son is like a big baby puppeteer, keeping us all on the string with his vicious mood swings. Worst of all, he seems delighted that he can do it. Many parents feel very disempowered by having to manage this illness. Families feel like they're walking on eggshells. What they've read in parenting books about discipline, consequences, rewards, punishments, none of it seems to work with this child. So quite a bit of distress is present in families, particularly after an episode of either mania or depression. So let me talk about what I refer to as the 8 principles for managing bipolar disorder in adolescence. And certainly there are more than 8. You might get a list of different 8 principles from someone else. But my work focuses heavily on the family and the family's role in helping to manage bipolar disorder. So the first principle, monitor the child's moods and know his or her early warning signs. This can be useful if you're a parent or if you're the clinician working with the kid to keep a regular mood chart and to know what the early signature is of a manic episode or depressive episode. How do they build? What symptoms develop early on? Daily monitoring mood symptoms. We usually start by encouraging the teen to keep his own daily mood chart. I'll show you an example of one in a second. And secondly, keep one yourself alongside of him or her. Compare the results from time to time if the teen is open to it. I usually say this is one of the few things you can do other than take medications to gain more control of your moods. Kids are often complaining about medications. I don't want to take medications that control my mood. Well, here's one thing you can do that's more behavioral, that puts you in the driver's seat. And then we'll want to know at the beginning of sessions, how are his or her moods affected by family conflict, school stress, peer relations, or medications? We'll see how in a second. So take a look at this particular mood chart. There are many of them out there. This was filled out. This was actually developed by a 13-year-old girl who was in our clinic. She didn't like the terms mania and depression. I can't say I blame her. She came up with her own terms, balanced, energized, super hyper, down, and angry. She even defined them for us. When she's super hyper, I feel good about myself. I talk faster. I like being high. When I'm down, I feel suicidal, short-tempered. I want to live in a bubble. When I'm angry, I feel pissed off, hate everyone, irritable. Now, she had a fair amount of fluctuation during the week, from balanced in the beginning of the week to down by midweek, and then slightly hypomanic by Saturday and Sunday. We also asked her to track her sleep-wake cycles. You can see that she had a fairly stable sleep-wake cycle during the week, and like many teens, started sleeping in and staying up later and later over the weekends. But in her case, that came at some cost in terms of an elevation of mood. So if kids keep this kind of chart over time, they may start to see patterns, or how sleep, how stress, how taking medicines may affect their daily mood cycles. Now, not everybody likes to keep a paper journal like that. There are now a number of different apps. And by the way, I don't make any money on these, so I can recommend them with a clear conscience. These mood tracking apps include such thing as the Smart Mood Tracker, eMoods, Moody Me, I'm not saying any one of these is better than the others, but some adolescents will have a much easier time with an online mood tracking system that sometimes will track their sleep as well, give them a nice printout at the end of the week or a nice graphic. So sometimes you can get teens involved thinking about it as an online exercise. Okay, so principle number 2, recognize the teen's stress triggers. So as I mentioned, episodes are often triggered by stressful events or stress within the family. So we need to know what kinds of stress elicit episodes of depression or mania. In the case of teens, often the trigger is a problem in peer relationships or what we call relational aggression, which, for example, in girls can take place over the internet, often about rumors being started about that girl by her friends/enemies. It can take different forms in boys, but often it's a problem with peers that the kid is bringing home and may explain why he is or she is so irritable when they get home from school, which is unfortunately often blamed on the parents. The reason they get so irritable is because you're not setting enough limits, when in fact it may be a carryover from the school day. Loss of romantic partners, particularly for the older adolescents, is a big trigger. Very intense family conflicts, especially if they're sudden, explosive, and involve falling outs between people. We've seen in our research that can be a predictor of a relapse. High parent-to-offspring criticism, what we call high expressed emotion, which is sometimes elicited by the child's behavior and sometimes just comes out of interactions ordinarily in the parent-child relationship, but we know that that's often a trigger for mood swings. Events that change sleep-wake cycles. I think this is getting to be more and more well known that bipolar disorder is partly a disorder of circadian rhythms, and that certain events that change sleep-wake cycles, examples are transatlantic flights, daylight savings. We've seen an increase in our clinic in mood symptoms since we had daylight savings last week. Changes in the sleep-wake cycle accompanying finals for people in high school and college. So those kinds of events can play a big role. And likewise, goal attainment events, this is perhaps the most surprising. When good things happen, when the kid achieves a goal, a valued goal, seems to be also when the manic juices start flowing and kids get overconfident, start believing they can do things they can't do. And so we have to be a little careful when something really good happens as well. And of course, sexual, physical, and emotional abuse, a predictor of all kinds of psychiatric symptoms, of course, and bipolar disorder is no exception. We know that many kids with bipolar disorder have abuse in their background. Now, one thing that comes up a lot in parents who are trying to cope with a kid, an adolescent who has bipolar disorder, is how do we handle the irritability, the provocations, the oppositionality? I'm thinking about the case where there is some stressful event. The kid is showing irritability and is becoming very oppositional. Parent may know what the source of the stress is, but nevertheless has to deal with this anger, aggressiveness. So there's a couple of things that I think are useful. I'm not saying any one of these will be the cure-all, but think about these as different tools in your tool case that you might be able to bring out at different times. First is ask yourself, is the irritability masking some underlying anxiety or depression or cognitive confusion? Sometimes when kids are having trouble keeping instructions in mind, particularly if they have comorbid ADHD, they may get irritable because they're having trouble following. So if they're told, I want you to get off that computer game, and then I want you to sweep your room, and I want you to then do the dishes, and then get ready for dinner, somewhere along the line they tune it out and forget what you've told them, and then they start getting irritable. But anxiety is often the underpinning as well, unpredictability. I ask parents to keep in mind the mantra, don't let your child's mood determine everyone else's mood in the family. That's really kind of a self-talk type of instruction. It's harder to put this into practice than, of course, it sounds. But if someone is irritable a lot, it's very important not to let the rest of the family's enjoyment of life be negatively affected. I'm a big fan of collaborative problem solving, and by that I mean involving the teen in solving a problem involving provocation. I like Ross Greene's basket approach. What are the issues I can let go? What do I strongly enforce? What should I negotiate? Like with terrorists, you have to negotiate with teenagers. And what is it that you can negotiate? What can you let go? And what things are really life or death issues or safety issues that have to be negotiated now? So that's a good way to kind of think about the problems. What category do they go into? Sometimes the best thing to do is to do some work on yourself. Try self-soothing, self-talk, breathing, meditation. Some parents give themselves a timeout if they feel like they're losing control. We teach communication training in our program, and one rule that we found useful is what we call the 3-volley rule. Namely, your part of the argument ends after 3 back and forths with the child. If you said no pizza tonight, and they have said, yes, I want pizza, and this has gone back and forth 3 times, your part of the argument is over, and you exit the confrontation before it gets destructive. Consequences people have mixed experiences with. Some say that they work. They certainly work with little kids. But with teenagers, they're tough. I think many of you may have teenagers and know that maybe when they were young, you could get them to stop doing things by counting. You better stop doing that by the time I reach 10. By the time they're 12, 13 or so, that no longer works. Well, with bipolar disorder, consequences have a mixed history, because sometimes all that does is make them more frustrated and wanting to up the ante until you find yourself giving consequences, taking everything away, and then it becomes impossible to implement. Creative consequences, not a bad idea. Taking a ride, bringing out over other relatives, changing the scene somehow, taking the kid out for a drive, not a reward, but really more changing the scene. And also keep in mind, if the kid or others in the house are in danger, should always involve the police. If the kid's running around with a knife or is threatening someone, or you really feel is in a position where he might hurt himself, the police should be involved. So think about those as options for dealing with irritability. Stabilizing sleep-wake rhythms. How do we do that, especially with teenagers who are already dysregulated in their sleep-wake rhythms? Here are some tips for sleep hygiene. Once again, track sleep patterns with an online application. That's if you can get the kid to do it, of course, that's best. To what degree do they have trouble every night? Do they have trouble falling asleep, or is it waking up in the middle of the night, or is it waking up too early? Do they sleep too little but still feel fine the next day, which is more of a manic symptom, or is it that they try to catch up on sleep during the day or sleep binge on weekends, more of a depressive symptom? We encourage people to keep a regular bedtime and wake time. This, by the way, for the clinicians, this is good with adults or kids. If you're working with a kid or an adult, try to get them to name a bedtime and encourage them to stick with that plus or minus 1 hour in any given day, and not to sleep binge on the weekends, as many of us are prone to doing. The more regulated the pattern, the more stable mood will be. Of course, the biggest problem parents often have of teens is separating the kid from the various screens, whether that be the cell phone, the tablet, the laptop, the television. We know that an hour in doing this right up to the time of bedtime keeps kids awake, and they still feel wired, and they want to go back and just play one more World of Warcraft game. Very important to have all that stuff off 1 hour before bed. And remember, you operate the modem. There are ways, of course, to turn off a phone if the kid is abusing privileges. Avoiding caffeine and other stimulants. When was the last stimulant dosage? Maybe if Adderall, for example, is being given in the morning and the kid takes another tablet or half tablet in the afternoon, it may be that he's taking it too late in the afternoon, at 4 o'clock in the afternoon, maybe too late if he's going to bed at 9 or 10. So sometimes you can talk to the doctor about moving the stimulant earlier or replacing it with another medication that's more slow acting. Avoid alcohol and marijuana. Don't fall into the pattern of, hey, marijuana helps my mood, it helps me sleep and all that. All different drugs can help people fall asleep. But whether you get the quality of sleep you need, you get enough REM sleep, or whether you experience a REM rebound when you don't smoke pot, those are all risks. We know that sleep is very tied in with mood. So that's got to be avoided, especially late in the evening. Exercise has an interesting relationship with sleep. Kids often want to work out right before they go to bed. That's often what keeps them up. If they're going to exercise, it should be earlier in the day, after school or before school, not right before bed, because that's going to keep them awake. Likewise, homework in the bedroom right before bed. I'll often say, I have to get this thing done. Then you look at the computer and you realize they're playing a video game again. They've got to turn it off the computer an hour before they go to bed. Finally, there are online sleep regulation programs. A pretty good one, not perfect, but pretty good, is sleepio.com. This is a 6-session CBT that kids can take that instructs them on different ways to work with their sleep and record when they fall asleep and examine cognitions related to sleep. Seems to be a very informative program. Okay, excuse me. I usually don't sit and talk to myself in my office that often, although maybe my staff would say I do and just don't know it. Fourth principle, know your position on medications. Notice that the principle is not take medications or make sure she or he takes medications. It's know your position on medications. We have quite a few, as you know. These are the current FDA indications for bipolar treatments, divided into whether they've been found to be effective for bipolar mania, bipolar depression, maintenance, or relapse prevention. And the ones highlighted in yellow have further been found to be appropriate and indicated for kids, or at least adolescents. So we're left with only a few, with lithium, aripiprazole, olanzapine, quetiapine, risperidone. We often use those in different combinations. Lamotrigine is becoming more and more popular. Its indication currently is for maintenance, namely keeping people well after they've gotten over an episode. Lamotrigine seems to be more effective for depression than mania on the whole. We don't really use much carbamazepine anymore. We know that the atypical antipsychotics, or second generation, as they're now being called, like aripiprazole, olanzapine, quetiapine, can cause weight gain, and in risperidone's case, elevation in prolactin. So we have to be a little careful with those. Some are more weight neutral than others. Abilify seems to be a little bit better than olanzapine, for example. So there's some balancing act that needs to be done. For bipolar depression, we don't have nearly as good data as we do for bipolar mania in terms of what works. The two options, olanzapine fluoxetine combinations or quetiapine, I don't see very many kids at all on the first one, OFC. So I have seen kids on Seroquel, but I think lamotrigine seems to be preferred in many cases, although sometimes Seroquel is used as a sleep medication. So let's see. Okay, troubleshooting medication adherence. Let's talk a little bit about the problems that people have with taking medicines, because that's often a big issue in these teens. What if they don't want to take medicines? What are the issues? How to work with it as a parent or as a clinician? Of course, it's always important to talk about the side effects. Many kids, many parents don't know that you can negotiate medication regimens with the doctor in terms of dosages or times when you take it. If the medication regimens are too complicated, for example, too many pills, sometimes they'll change it to single dose aripiprazole instead of having multiple medications. So side effects are a part of medication non-adherence. And sometimes the issue is forgetting. If the kid is responsible for his or her medications, then we need some strategies for pill storage and use, some reminders, some pill boxes perhaps, some watch alarms that remind the kid when to take what, although most of them don't want to alert their friends that they're taking medications. So sometimes parents just dole it out in the morning. What I find is one of the strongest issues to consider, particularly when we're talking about 17, 18-year-olds who are working on independence from their family, medication can become synonymous with control by one's parents. They feel like, gee, I've been taking these medications all these years. I've never even asked myself whether I'm bipolar or not. So why should I continue doing that? My family members are just pressuring me. Sometimes a kid hears different messages from different parents. So they're living with dad during the weekends and with mom during the week. The two parents don't agree on whether their medication is useful, and the kid ends up following one parent's advice and not another's. So it's very important that the parents be on the same page. And the goal of this, of course, is to get the kid to feel like they're making the decision themselves. They have to feel some ownership of it if they're going to continue in adulthood. For kids who have creative pursuits like music and art, sometimes they feel like medications blunt them or help make them give up emotions. Another argument, I think, for seeing if dosages can be adjusted. They're having trouble playing their violin or painting while they're taking lithium. Can it be adjusted? Are there other medications that would work just as well without the side effects? And a more subtle issue, I think, is grieving the lost healthy self. Ellen Frank and her colleagues have talked about this process in both depression and bipolar disorder. Sometimes people, particularly when they get into their late teens and 20s, start grieving over who they were before they were ill, before they were taking medications, wanting to get that person back. And they start thinking that medication is what's keeping them from becoming the person they used to be, their lost healthy self. This can be, I think, addressed either in family sessions or in individual. Sometimes it's better in individual sessions to be talking about that. Fifth principle, develop a mania prevention plan. This is what I was starting to get into earlier about being able to identify early warning signs, develop prodromal signs of past episodes. What stressors or circumstances have these occurred in? What strategies can you implement? What can if you're a parent, what can your spouse, your parents, your siblings do? What can the psychiatrist, what can the therapist do? What are the obstacles, and where is the emergency contact information? So let's say you've gone through a couple of episodes already with a teenager, and you're at a point where you can recognize the beginnings of those episodes. He or she sleeps less, or becomes more irritable, or starts talking faster, or becomes very interested in online businesses. That may be the prodrome, or the prodromal signature, as we call it, for that particular kid. So what can you do when this starts to happen? What can other people around you do? So we work with families in our family treatment on mania prevention. A prevention action plan can look like this. There is a place to record what are the stressors, what are the triggers typically. There may be something like changes in sleep-wake cycles, It could be the beginning of vacation and the end of the school year. It could be finals week. It could be breaking up with a relationship or extended family conflict. Early warning signs. What are the coping skills? What obstacles do you think you'll encounter? And what are some of the things you can do? Well, if the adolescent is headed towards mania, we think, in other words, they're hypomanic, even though they're apparently taking medicines, certain things behaviorally that can be done, of course, calling the physician to have medication levels checked, maybe a change is added. Sometimes the physician even decides to write out the script ahead of time for an adjunctive antipsychotic, perhaps. We encourage them to stay away from driving, to leave their credit cards at home, especially if they've had trouble in the past with overspending. A very important one, if they're going out at night, they should bring along someone they trust with them. So a cousin, a sister or brother, a good friend who doesn't tend to leave them into trouble. If they want to be going out late at night because of hypomania, they need to have somebody with them who makes sure they don't make bad decisions. In terms of life decisions, if they're saying, I'm going to pack my bags and move to California and become a rock musician, we encourage them, use the 2-person rule and the 48-hour rule. Most of you who've studied CBT know about these. Check with 2 people close to you and see if they agree with what decision you're thinking of making. Wait 2 days and see if your decision is still good on Thursday. If it's a good decision, it'll be good on Thursday as well. So we try to build in some delay of gratification. Here's what a prevention action plan might look like. This particular patient, Phil, was triggered by arguments with his dad. He was fired from an after-school job, probably in part because of his irritability. His early warning signs meant sleeping less, getting up during the night, being obsessed with video games. He would talk about ways of making money loudly. Coping skills, trying to keep a regular bedtime, getting his medications checked. His stay away from friends who make me want to smoke weed, which is in his case was a trigger. Obstacles, computer games may involve other people I want to talk to. Where is everybody's phone number? So you kind of do a dry run. If this were to happen today, what would you do differently? And then, of course, if there is an episode, you want them to implement these plans and hopefully come back and rework the plan if it wasn't effective. 6th principle, working on communication and problem solving. I'm going to rush through this a little bit so we have enough time for questions. But part of our work involves improving family relationships and ability to communicate directly. When a kid has mania or depression, it can be very hard for parents to know how to approach them, to know how to talk to them. And this brings up the whole question of how can the family help other than supporting use of medication, which is, of course, a very important role, but they don't want to be stuck in that role only. So one thing is to help the adolescent get other treatment and support services, maybe an individual therapist, help with an IEP, an individualized educational plan, or 504 plan. Very important to maintain as tolerant and calm a home atmosphere as possible, especially in the period after an episode. And that's, of course, when parents are most provoked. But it can help for them to start thinking again about this. Is this something I have to go to the mat about, or is this something I should negotiate, or is this something I should ignore entirely, the Ross Green approach? But also what's controllable and what isn't that the kid is doing. To what extent are they able to control their behavior? Are they doing this on purpose, or is this partly a biologically driven behavior? Very important to set expectations lower, especially after an episode. The kid may look good, but may not be able to fully function well. Important to remember the healthy siblings, that the kid with the disorder can soak up a lot of time from parents, and very important to keep in mind that even though other kids are seemingly doing well, they still need plenty of parental attention, which really makes people feel quite divided sometimes. Very important to keep regular family routines, know your own limits, and what I call substance-free homes. If you're a person who uses substances yourself, make sure they're out of reach of the teenager, because he or she will be much more likely to use those substances during episodes. We have a series of communication skills we use. Many of you are familiar with these: active listening, making positive requests for change, communication clarity. This is generally done through role-playing and sessions, how to give a compliment, how to listen when somebody else is speaking, how to ask for a behavior change without criticizing, without saying anything negative. For example, we'll take two members of the family through an active listening exercise, where one speaks, the other one simply attends, gives some sort of nonverbal acknowledgement, asks questions, paraphrases, just like we all learned when we were taking therapy 101, how to be a good listener. And this tends to create a sense of collaboration, especially when parents have to be able to stop themselves from giving advice or going beyond what the teenager is actually saying. So this sort of thing can create more of a sense of collaboration. Let me talk a little bit about reasonable accommodations at school. And reasonable accommodations, of course, is much more awareness with the passing of the Americans with Disabilities Act, that every child is entitled to education in the least restrictive environment. Bipolar disorder does count as a form of disability, and for that reason, you can get an IEP related to the kid's bipolar disorder. Now, parental advocacy in the school setting, many of you have much more experience with this than I do, but I can tell you a couple of things we've seen. Of course, trying to develop an IEP, but even more importantly, to developing the IEP is to monitor as follow-up. That's even more true of a 504 plan, which doesn't have the same legal backing as an IEP. And many parents say that they really have to stay on the teachers to try to make sure this is followed. But the teachers aren't the evil ones here, because they have 30, 40 other kids to worry about, and these things can fall by the wayside. So very important for the parent to be an advocate. Sometimes it's helpful to get teachers to learn how to distinguish bipolar disorder from ADHD, or as some call it, severe emotional disturbances. My experience, it doesn't help to group bipolar disorder with autism, ADHD, emotional problems of other kinds. It really has its own features, and all those disorders have their own features. What is it we want them to do for kids with this particular array of problems? One is to develop a behavior management plan at school. This might involve, for example, later starts to the school day. If the kid is taking Seroquel or another atypical antipsychotic, it may be harder for them to wake up in the morning. They may have trouble with sleeping in. They may miss their early classes, or if they do get to school on time, they simply can't concentrate. They may need more breaks. They may need more escape hatches when they're triggered by something in the classroom. They often do get triggered. They tend to get overstimulated, so smaller classrooms may be useful. And very rarely do parents get everything they want, but the school can make a good faith effort to address at least some of these difficulties. Excused absences for medical appointments. There are a lot of medical appointments in bipolar disorder. You may have a family therapy session. You may have an individual therapy appointment, medication management. Sometimes kids get some sort of neuropsych, cognitive rehabilitation as well. And all these things have to be excused. And many of our parents decide on alternative school environments when the regular school system isn't giving them what they want. Of course, any change you make has to be with the kids' buy-in. With teens, of course, by the time they're 13, 15, 17, they no longer take it for granted what their parents think is best for them, and they can outright refuse to go to school. if it's not the right school, or refuse to talk to school counselors, or don't want their teachers to know about their bipolar disorder. So very important to do this in conjunction with the child. That brings up the more general question about, do you tell others about what's going on? To what extent do you tell people, my son or my daughter has bipolar disorder? On a practical level, I wish it weren't this way, but there is still a stigma in our society that we have to be aware of. So when you decide you're going to tell someone else about your son or daughter's bipolar disorder, what is the purpose? Are others in that person's milieu affected by the kid's behavior? Is one of the parent's friends? Is it the teacher? What ideally do you want them to do with the information? Some parents do it because they're distressed and they need someone to talk to, understandably. But I would encourage them to use a support group as the setting for disclosure, because I've had too many parents say it backfired later when the kid invited friends over for a birthday party, but they didn't come because their parents were afraid of them. They were afraid of sending their kids over to a kids with bipolar disorder's house. So again, the adolescent has to be involved in this discussion so that she doesn't feel that her confidentiality was violated. So these are complicated issues and good ones to discuss with a therapist. Final principle for caregivers, I think it's very important to attend regular family intervention sessions. I'll tell you about our program in a moment, or peer support groups, of which I have a lot of connections and admiration for. By family intervention sessions, I usually mean sessions that involve parents, the kid with bipolar disorder, if possible, the siblings, and anyone else who lives in the house who may have a caregiving role vis-a-vis the kid. Family sessions should be psychoeducational, that is, focused on the disorder and how to manage it. What do we know about the disorder? How can family members be helpful? After an episode, weekly or biweekly is optimal, once every week or every 2 weeks. It tends to be a good context for self-disclosure, particularly these peer support groups. Consider peer support groups, such as those offered by DBSA, or that's the Depressive and Bipolar Support Alliance, or the National Alliance for Mentally Ill. International Bipolar Foundation has online support groups. Some people prefer those. In general, they say that other parents and other caregivers often have unique recommendations that they can't get from a therapist. Our work, our treatment program is called Family Focused Therapy, or FFT. Its features are it's given in 12 to 21 outpatient sessions over a period of between 4 and 9 months. Why such a broad range? We usually use fewer sessions if we're working with a kid who's at risk for bipolar disorder. For example, has the early warning signs but hasn't had an episode yet, may not need as much as a kid who's had numerous episodes. This is spread over 4 to 9 months. Begins with an assessment of the kid's diagnosis and the family environment, an engagement phase of the family, but then psychoeducation about the disorder. What are its symptoms? How do we recognize when an episode is beginning? How do we treat it? What self-management techniques can be brought to bear? So the very things we've been talking about for the last 45 minutes are covered in this program, with the kid as the primary source of this information. So we say to the kid, you're the expert in this, you've gone through it, educate us about what you've gone through, what's helped, what your parents have done that have helped and not helped. Later on, we move to communication skills, as illustrated by the use of active listening, positive requests for change, balancing positive and negative feedback, and a component of problem solving, which involves identifying specific family problems and going through the steps of trying to solve them and implement those solutions. So those are often related to school, behavior around the home, in older kids or young adults. Sometimes it's about relationships, even child caretaking. We've done 9 randomized trials of FFT with medications. I don't, of course, have time to go through them all, but there have been a total of 840 patients in these trials. 5 have been with bipolar adults, 2 with bipolar teenagers, 1 with kids at high risk for bipolar disorder. They were on average about 12 or 13. And then we had 1 of adolescents and young adults at risk for psychosis. They were on average about 17, and most of them had early psychotic symptoms. Comparisons have usually been briefer forms of psychoeducation or individual supportive therapy. We've always combined it with medications. And the findings very consistently have been that patients in family treatment have greater benefits over 1 to 2 year periods in symptom trajectories, time to recovery, time to recurrence, and psychosocial functioning. So kids do better in this treatment than they do in just medication only or medication with some case management. We haven't shown yet that it's better than any individual therapy, except it does outperform individual supportive therapy. But future we'll be wanting to look at DBT as a comparator or a CBT. So we have reason to believe that this is a potentially good treatment. So let me summarize once again. These are the 8 principles, and then we're going to open it up for questions. Monitor moods daily, recognize stress triggers, stabilize sleep-wake rhythms, know your position on medications, develop a mania prevention plan, work on family communication and problem solving, obtain reasonable accommodations at school, get regular family sessions, or join a support group. I realize that's a lot, and you may not be able to do all of them at the same time, but even doing 1 or 2 of these can really be helpful for a kid whose mood is cycling. One thing I think we're going to see more and more of in the care of adolescents with bipolar disorder are integrated systems of care. In other words, the collaboration across agencies and schools and family, kids, to try to improve access and therapy, medication, education, support services. So there's a move towards making these more integrated, sometimes even in the same physical property where the school and the health centers can all meet in kind of a community medical homes model. I think that's got a lot of promise in the treatment of these disorders. Of course, we're all aiming for personalized medicine, what treatments work best for what kids and what settings. The model for that is treatment of breast cancer. What genes can we point to that might predict what treatments would be most effective? We are not there yet, though. We don't yet know what treatments work best for what kids, and certainly we don't know that for psychotherapy treatments. I think we're going to see a lot of more use of technology-assisted care, smartphones, tablets, not only to exchange symptom information, but maybe even for some of our treatments. Some of our treatments have to do with psychoeducation, which presumably could be done in an interactive online format, although this hasn't been studied very much, so there may be some problems with it that we haven't anticipated yet. But these are some of the areas we'll see more of. I want to close with a quote from Kay Jamison. If any of you have not read An Unquiet Mind, I highly recommend it. It's a novel by Dr. Jamison has bipolar disorder herself and went through a series of manic and depressive episodes when she was a professor and still is a professor, in fact. She says this: I cannot imagine leading a normal life without both taking lithium and having had the benefits of psychotherapy. Ineffably, psychotherapy heals, makes some sense of the confusion, reins in the terrifying thoughts and feelings, return some control and hope and possibility of learning from it all. It's where I have believed or have learned to believe that I might someday be able to contend with all of this. So I hope I've convinced you that along with medication, we need to do quite a bit in therapy, and people need to do quite a bit of individual self-management to be able to stabilize, and family management to be able to stabilize this difficult illness. Some shameless self-advertising. This is our book on bipolar teenagers, what you can do to help your child and family. So this is a lot of what I told you is in this book for parents. We also have a book for clinicians on drug treatment and psychotherapy. My colleague Michael Gitlin is an MD, and we've explained both different algorithms for medication treatment as well as psychotherapy. And this is who we are. I'm on the far right. The rest is, let's see, that's Dr. Angus Strawn on my right, and our team, our great team of therapists, psychiatrists, research assistants. So I thank you for your time and happy to take questions.
Good. David, thank you very much for an extraordinary, clear presentation. So I want to jump in to a couple of questions. One, you spoke a little bit about the issue of substance abuse, substance misuse. What should a parent do? Their teenager is using alcohol to excess, marijuana, perhaps other drugs. What should they do?
You know, I think this starts with a conversation where the parent says, I understand this is happening. I understand it's happening more often than we've been talking about. And of course, the teen will deny it. But the parent needs to show awareness in as non-judgmental a way as possible. What are we going to do about it as a family? Are you willing to see somebody? Are you willing to go to a group? How about if I go to a group with you? I would hold at first with the consequences. In other words, not right away saying we have to go out. You're gonna have to do that, or I'm going to make sure you get to treatment. Otherwise, you won't be able to use the car. That kind of thing, I think, should come later. I think you can use consequences, but in my experience, they don't work particularly well. They don't work as well as concern monitoring, restricting the kids' activity to some extent, to the extent possible, probably making parents of other kids who are interacting with your kid aware. And eventually, of course, you may have to point to an inpatient program for substance abuse or chemical dependency program. At minimum AA, but sometimes inpatient is necessary. So I think it's a multi-step process.
Good, very, very, very helpful. I want to ask about what parents should do if with younger children who seem to be having some of the symptoms that you described, and that they're really concerned about them.
Right. Yes.
What should they do, and does early intervention have an effect upon the overall course of the illness?
Those are good questions. First, I think the very first step is to get a full diagnostic evaluation. So there has to be someone with expertise in childhood and in childhood psychiatric disorders. They don't necessarily have to be an expert in childhood bipolar disorder, but someone who can recognize it if they see it. That will require coming in for a series of interviews. There is no blood test you can do, not currently. There may be in the future. Beware of people saying, oh, you need to have his brain scanned, because in reality, we don't have any brain scans that distinguish bipolar disorder from other disorders, not yet. So first do a diagnostic evaluation, which is really questions and answers and history and symptoms. Make sure medical records are forwarded to the person who's doing the evaluation. Early intervention programs, there aren't too many out there yet. Our program at UCLA, Family Focused Treatment Program, is one. We work with kids who are children of bipolar parents who have early signs that may be indicative of bipolar disorder, and that's a study examining our family-focused treatment as a preventative device to see if it does prevent the onset of the disorder. There have been various attempts at stabilizing sleep-wake cycles as an early intervention. I think that's a good habit to get kids into health-wise. But also I think the school needs to be involved. Is the kid having trouble in school? And what kinds of accommodations are going to be needed, whether this turns out to be bipolar disorder or not. Some parents opt for the medication option early on. Some say, I'm going to wait. I can understand both positions. since you may have weight gain on the one hand, but you may have uncontrolled mood on the other. But it's always a good idea to see what the options are, educate yourself about what the kid may be running into.
Good guidance. One last question in our remaining time. There's a spectrum in terms of the severity of bipolar disorder or the response to treatment. And I'd like you to tell us a little bit about that, and then what to do if you have a child who is less responsive to treatment.
Less responsive to treatment. Okay. Yes, there is a spectrum of the disorder, and there's a spectrum of response to treatment. We have the different levels. For example, bipolar, not elsewhere classified as a milder form, usually, not invariably, but usually a milder form. Bipolar 2, followed by bipolar 1, and then some people would say bipolar 1 with psychotic symptoms is the most difficult to treat. When you have a kid who's not responding first to monotherapy, meaning one medication at a time, it's important to consider, of course, adding an adjunctive, and the doctor often will recommend this early, like let's combine lithium with an antidepressant, or let's combine it with an atypical antipsychotic. The only problem there, of course, is that very quickly the kid can be on 3, 4, or 5 medications. It's very important to know if there's any kind of biological imbalance, for example, in thyroid hormones, to have a full workup to see if any of the levels are off or unexpected. And we have had kids who weren't responding to medications, and then when they took a thyroid supplement, things went better. Some kids do better after puberty. Some do better with the combination of psychotherapy and medication instead of just continuing to add one more medication. They do better with some combination of therapy and medications. And again, if some of the triggers for these episodes are school-related events, consider a different school setting, especially if the kid is showing symptoms after some sort of school rejection event.
All, again, very good guidance. And I think the most important take-home message in the broader sense is for parents, don't give up. Keep trying. Keep going at it, because often people who may not have done well at the beginning ultimately are able to do well with the proper treatment and support.
Absolutely. I'm glad you mentioned that, because one thing we are seeing is some of the kids that we saw in our clinic when they were 13 or 14 are now young adults, and I've been surprised how some of them are doing extremely well. They're in college, they're more stable. Some of them are taking medication, some of them aren't. I wish we could identify at a time what kids would follow what trajectory, but I think there is reason to be hopeful.
Good. Well, certainly the work that you and your team do is a reason to be very, very hopeful. And I want to thank you for presenting today and for all the work that you have done and continue to do. I also want to thank everybody who joined us today. All of the research we fund is made possible through private donations. And if you'd like to make a gift, please visit our website, bbrfoundation.org, or call us at 1-800-829-8289. This webinar has been recorded, so if you've missed any portion of the presentation or would like to share it with a family member or friend, visit our webinar page on our website. I hope you'll join us again next month when Dr. Mark Karen, Professor of Cell Biology at Duke University Medical Center and a member of the Foundation Scientific Council, will present a webinar on schizophrenia. This will take place on Tuesday, April 12th at 2 p.m. Eastern Time. Thank you all again. Enjoy the rest of the day. Take care.
Right.
Thanks. Bye.